Hi, good morning, folks. So, good morning to everyone. Myself, Dr. Pankaj. I'm pediatrician by profession and teacher by passion. So, welcome to all in this brand new series on Nelson Pediatrics, which is based on previous year asked topics in NEET SS or INA-SS Pediatrics. So, this will be very exciting series. This is the first lecture of this series. We will start with the new topic, that is interferonopathies. Basically, this is not PYT. This has been added in new Nelson 22 edition. So this is a potential topic. So we'll start our series with this first topic. So without further delay, let's start. Okay, so we are discussing type 1 interferonopathies. These refers to a group of inherited autoinflammatory disorders that are characterized by dysregulation of interferon 1 pathway. Basically, what I want to say is that something, the disease which is caused by interferon. Basically, interferonopathies is called like type 1 interferonopathies. We'll discuss it. What does interferon are? Okay. So first thing, what the interferonopathies term came, or what is this discovery thing? Okay. So researchers were doing the research and they saw striking resemblance of these three syndromes, which is called Aicardi Goiter syndrome AGS, encephalopathy, congenital viral infections, monogenic systemic lupus erythematosus. Means the one patient having all these three disease, they thought if these diseases are occurring in a concurrent manner, there must be some common pathophysiology behind these. So researchers went into deep and they thought, yeah, this something is there. So they thought, could it be interferon? Okay, so this is very exciting thing. Interferon can cause these all Aicardi AGS, encephalopathy, congenital viral infections, and SLE. Okay, so basically, what are interferon? Interferon are, they are expressed in inflammatory polypeptides that are induced by microbial and viral nucleic acid. Okay, to simplify it, let it simplify. So what are interferon? Actually, interferon, yeah, what are interferon? This is our body cell. If any microbe, let's say this is virus or bacteria, if it attacks on our cell produced interferons. Okay, what the interferon do? They go to the infected cell, and here are interferon receptors. They attaches to interferon receptor and they induced interferon gene via which pathway, which is very interesting, JAK-STAT pathway. These interferon genes produced some protein which kills infected cells. So let's revise once more. This is basically the mechanism of safety. When body cell is infected with virus or bacteria, they produce interferon. Interferon, actually what they does, they attach on interferon receptor, and they act via JAK-STAT pathway, and by that they produce interferon gene. Interferon gene produce a protein and they kill infected cells and body cells. So this is basically a defense mechanism. Any alteration in this mechanism or overdose of this mechanism cause diseases which is called as interferonopathies type 1. We'll discuss them later. Okay, so yeah, so what are the mechanisms? So this is actually 5 type of mechanism are there which can be attributed by which disease can caused by these mechanisms. So just go through these mechanisms once. So what they say, this is loss of function variant of gene that encoded enzyme responsible for DNA or DNA RNA hybrid molecular degradation. Okay, anything which is actually producing more interferon, this will be mechanism. Okay, so first thing, this is DNA RNA hybrid molecule degeneration. Second thing, okay, the variants that leads to activation or reduction of activation threshold of intracytosolic nucleic acid sensors. So sensors ka threshold they are doing down, so this is the mechanism. Third, gain of function variant of positive interferon signaling regulators. Anything which is upscaling interferons, gain of function mutation of this thing will cause interferonopathies. The fourth point, loss of function mutation of negative interferon signaling regulators. And fifth, the proteasomal dysfunction leading to unfolded protein response and downstream interferon pathway activation. Basically, for this group of disease to happen, interferon pathway should be upregulated. Anything which is doing upregulation of this pathway, which will induce the interferonopathies. Okay, so just you have to remember these names. Okay, these names are sufficient. This is a diagram from Nelson textbooks of pediatrics, which is showing the same thing which we have discussed. This is actually we don't need to go detail into this. These mechanisms are same: loss of DNA RNA degradation, activation of intracytosolic acid nucleic acid sensors, gain of function mutation of positive interferon regulator, loss of function mutation of interferon, negative interferon regulator, and fifth, proteasomal dysfunction. So for exam purpose, just remember these 5 mechanisms. They are easy to remember. Don't go deep into them. Okay. What is more important is the diseases caused by this interferonopathy, a spectrum of diseases. We will discuss some common or important diseases under this heading. So first we are discussing is Aicardi-Goutieres syndrome, AGS. Okay, so what is saying, this is actually this is due to interferon 1 signaling, excess signaling. We know we are reading interferon. Okay, gene. So genes are TREX1, RNA SAH2B gene, ADAR1 gene, IF1H1 gene. So remember some genes, like these genes are important, so remember these genes. Okay, so this is autosomal recessive or dominant. Pathogenesis, I told you, this is upregulation of interferon stimulated gene. Okay, clinical features. This is very interesting. Okay, infant, if it is irritable, developmental regulation, dystonia, seizures. Yeah, this is very vague features. Okay, prenatal presentation, pseudo-Tourette syndrome. This is very, very important. This is the potential question from this slide, which is pseudo-Tourette syndrome caused by AGS. Okay, microcephaly, then liver dysfunction, seizures, neurological regression after normal development, fever, hepatomegaly, thrombocytopenia, skin rashes. These are like vague symptoms, but yeah, they are symptoms of this syndrome. How you will diagnose? You will diagnose with elevated interferon type 1 in CSF and imaging like intracranial calcification, genetic testing by mutation in AGS gene, treatment by, because this is caused by JAK-STAT pathway, so JAK inhibitor like bezisterimab and ruxolitinib and hydroxychloroquine also. Prognosis is variable. So from this slide, if something has to be remembered, which is this is actually the gene, okay, then imaging intracranial calcification, cerebral atrophy, CSF elevated type 1 interferons, and some neurological symptoms, thrombocytopenia and skin rashes. So this is actually good enough for AGS syndrome for exam purpose, definitely. Next disease under these, okay, sorry. Yeah, as we are discussing the AGS, you can see this is image from Nelson textbook of pediatrics. Chilibians like features we can see from this picture on fingers, on pinna, CT brain showing intracranial calcification. That's why this entity is thought to be pseudo-Torch syndrome. Okay, interesting now. And interstitial lung disease pattern we are able to see. So this is this picture can be asked. So just this keep in this mind of this picture. This can be asked. Okay. Next entity is spondylio and chondrodysplasia. So SPENCD. This entity is important. So what you are able to see, this is autosomal skeleton dysplasia with short stature, platyspondyly and enchondroma. So this is basically important. Anything like skeleton dysplasia with the short stature, with platyspondyly and enchondroma, the diagnosis is SPENT. Okay. So the gene is the gene ACP5 encoded TRAPS. So this is actually what they does. They does loss of TRAP, elevated osteopontin, increased interferon alpha production. What are the clinical features of this is skeletal features? Sclerosis, short stature, and chondroma we have discussed. Okay. Neurological like intracranial calcification, spasticity, autoimmune like SLE like features, okay, hypothyroidism, Raynaud phenomena, vitiligo, diagnosis, genetic testing by ACP5 mutation, imaging, intracranial calcification, labs, ANA and APLA positivity. Okay, so again to summarize from this slide, what is important, I will highlight. So combination of skeletal dysplasia, short stature, platyspondyly and enchondroma, the diagnosis is SPENT. Then the gene is ACP5. This encodes TRAP. This is important. And enchondroma in clinical features, intracranial calcification, SLE-like features are important. Okay. Diagnostic, again genetic testing, ACP5 mutation and autoantibody positivity, because this is SLE-like features. So these are the crux of this disease. Next we'll go to STING. So STING associated vasculopathy with onset in infancy. Okay, so this is SAVI. So SAVI is important, I feel. Okay. So what you can see, this is rare autoinflammatory disorder caused by gain of function mutation of TMEM173 mutation, which is important. Okay, so pathogenesis, you can see this pathogenesis is also there. Then what you can see, clinical features like fever, elevated inflammatory markers. Then you can see the rashes, vasculopathic rashes like plaques, nodule, necrosis, which is important, cutaneous features, yeah. Pulmonary like adenopathy, ILD, musculoskeletal, myositis, arthritis, arthralgia, and oral nasal aphthous ulcer, oral ulcer, nasal sputum perforation. The diagnosis is by leukocytoclastic vasculitis and neutrophilia, and autoantibodies like ANA, anticardiolipin, and CNCA mimics granulomatous with polyangiitis. This is very important. Genetic testing by TME M173 mutation. Important, it has been misdiagnosed as GPA, possibly due to CNCA positivity, and it is associated with severe pulmonary complications. Okay, so this is very important. So let's discuss important features of this, which has to be remembered. So first, the gain of function mutation of TME M173 mutation. Second, cutaneous features like vasculopathic rashes. Third thing is like pulmonary interstitial lung disease. Okay, then diagnostic like leukocytoclastic vasculitis, autoantibodies, CNCA mimics granulomatous with polyangiitis. Genetic testing is TME M173 mutation, and the misdiagnosed as granulomatous with polyangiitis and with severe pulmonary complication. So these 3-4 things you must remember from this disease. Okay, so again this is SAVI. So in SAVI, like auto amputation is the feature. Okay, so this can be asked as image based question. So this is actually a telangiectatic lesions on cheeks because of deep tissue distraction. So this looks like distracted tissue, and on chest CT bilateral hilar lymphadenopathy is there. Okay, so these can be asked as image based questions. Okay, next. So another syndrome is chronic atypical neutrophilic dermatosis with lipodystrophy and elevated temperature candle. So very fancy name. So let's see. So this is caused by proteasome immunoproteasome function. It is caused by PSMB8 mutation, and which is a regulator of POMP gene. Don't go deep into pathogenesis. Okay, clinical features. This is actually early onset fever with systemic inflammation. Cutaneous features like neutrophilic dermatosis, annular erythema, eyelid swelling, panniculitis. Lipodystrophy. It's like progressive loss of fat from face, trunk and upper limb in early childhood. Musculoskeletal, arthralgia, severe joint pain, contraction in adulthood. Other inflammatory features like myositis, aseptic meningitis, episcleritis, nephritis, pneumonitis. Autoimmune manifestations like Coombe-positive hemolytic anemia, hypothyroidism. Diagnostic. Histology is actually suggestive of immature neutrophil dermis. Genetic testing mutation in PSMB8 gene, and pathogenesis by type 1 interferon pathway. Okay, so this keynotes like begins in infancy with systemic inflammation, and distinct feature is viruses, eyelid swelling and panniculitis are hallmark skin finding. So this is very exhaustive kind of disease. So let's discuss common features. First, remember name the disease candle. So this is proteasome immunoproteasome function, which is defective. Gene is PSMB8 mutation, and the gene regulatory protein is POMP. Okay, early onset infancy with fever. Cutaneous is like neutrophilic dermatosis. Lipodystrophy is the hallmark, and myositis, Coombe-positive hemolytic anemia and hypothyroidism are autoimmune features associated. The genetic testing is by PSMB8 gene. Pathogenesis is by type 1 interferon pathway we have seen, And again, Wallis's eyelid swelling and paniculitis are hallmark clinical finding. Okay, lipodystrophy, joint contracture. So just remember these highlighted sections of from this disease. This will be good enough. Next, so ISG15 deficiency and USP18 deficiency. So actually, don't try to remember the full name of these things. But this is disease mimicking AGS. This is one question, because it causes intracranial calcification, seizures, systemic inflammation. Okay, so patient actually do not show increased vulnerability of viral infections. Okay, so this is actually related to antiviral response. Don't remember that much. It was about ISG15 deficiency, then USP18 deficiency. So this is actually neonatal autoinflammatory disorder caused by recessive loss of function mutation of USP18. Clinical features: neonatal onset systemic inflammation with rapid demise soon after birth. Pathogenesis: absent USP18 removes negative regulation of interferon 1 signaling. Okay, so ISG15 deficiency present phenotype overlapping ASG without viral susceptibility, and USP deficiency uniformly fatty neonatal period due to severe interferon dysregulation. Okay, so again this is very exhaustive, so we will mark some important thing. So ISG15 is mimics AGS, and this is patient don't show increased vulnerability to viral infection despite impaired ISG15. Again, this is highlighted in this. Okay, USP18 deficiency. This is actually neonatal severe neonatal disease which is uniformly fatal in neonatal period due to severe interferon dysregulation. So just remember these highlighted points. Okay, again, the next disease in the spectrum is SMS. This is actually singleton Meriten syndrome. So this is autosomal dominant. This is gain of function mutation in IF1H1 gene. Pathogenesis: excessive activation of type 1 or type 3rd interferon response. Clinical features: early onset aortic and valvular calcification, which is very important, acroosteolysis, glaucoma, and this may mimic SLE or AGS phenotype. Okay, so yeah, this is genetic or environmental factors. So what we can remember from this disease is like this is actually what we can remember. Yeah, this is autosomal dominant, gain of function mutation in IF1H1 gene. Okay, early onset aortic and valvular calcification, glaucoma, and this mimic SLE or AGS phenotype. Next disease in the spectrum is X-linked reticulate pigmentary disorder, XLPDR. Okay, so this is a rare X-linked dominant disorders which is important. Mutation in intron of Pol A1 gene. Pathogenesis is due to type 1 interferon increased production, which is the common pathophysiology of these diseases. So clinical features in male like early recurrent pneumonia, bronchiectasis, diarrhea, failure to thrive, diffuse skin hyperpigmentation, hypohidrosis, corneal scarring, enterocolitis, urethral stricture, and distinct facial features. In female carriers, pigmentary changes along Barashko's line. So skin hyperpigmentation is diffuse pattern appears in early childhood, and systemic features like respiratory and GI features are there. So again, this is very exhaustive detail. So we'll highlight important. First, remember the disease name. Second, this is X-linked dominant. Third, this is due to mutation in intron of Pol A1, and again this is interferon disease. And male, early onset pneumonia, then failure to thrive, enterocolitis and diarrhea are same, corneal scarring, hypohidrosis, and pigmentary changes along Bell-Ashko's line. The third thing, skin hyperpigmentation is there. Okay. So next disease under this spectrum is DNA's second deficiency. This is autosomal recessive, causing a form of monogenic SLE. So this is very straightforward MCQ for your upcoming exam. Gene DNA's second deficiency, as the disease says, and pathogenesis again interferon 1 excessive production. Clinical features: neonatal onset, severe anemia, thrombocytopenia, hepatosplenomegaly, which are non-specific. Childhood onset like MPGN, lipodystrophy. Laboratory features like high titers of ANA, dsDNA antibodies, and interferon. So the extracellular DNAs can also cause monogenic SLE but are not considered as interferonopathies. So this is DNA's second deficiency, is called interferonopathies. So yeah, so this is again, we'll remember important points from this. So like this is a form of monogenic SLE, DNA's second deficiency. Okay, neonatal onset, severe thrombocytopenia, anemia, hepatosplenomegaly, and laboratory finding high titer of ANA, dsDNA, interferon, and interferon stimulated gene expressions. Okay, next we'll go to SLE, because these disease mimic SLE na, so we'll discuss SLE. So SLE in interferon, like increased interferon levels are seen in SLE. Okay, so SLE also somewhat has mechanism which involves interferon. So like don't remember the whole slide. Interferon correlation, like interferon signatures are there. Okay, interferon inducers are there. What is important is the risk loci. Over 100 risk loci are linked to SLEs. So the most important question is monogenic SLE. So this monogenic SLE is caused by DNase second, DNase 1L3, DNase 1, all linked to interferonopathies. So in this slide, which is SLE and association with interferon, so this is actually basically interferon signature, interferon correlation, interferon inducer, and monogenic SLE is caused by these: DNA second, DNA SE1L3, DNA SE1, all linked to interferonopathies. Okay. So summary of JDM. JDM is mechanism of JDM somewhat involved interferon also. So this is aberrant type 1 interferon signaling. Okay. Interferon and disease activity is correlated. Okay, and in interferon also JAK inhibitors can be used in JDM because it involves this interferon. Okay, so treatment, like we have seen now, this is caused by JAK-STAT pathways, the main pathway. So we can inhibit the JAK pathway. So like JAK inhibitors we can use, JAK-STAT pathway we can inhibit, because which we have just seen, it involves JAK-STAT pathway. So what are the drug? Tofacitinib, just remember these drug. And tofacitinib is also approved for psoriatic arthritis, ulcerative colitis, polyarticular J. Okay, so this is important. Just remember these. In this interferonopathies, JAK-STAT pathway inhibitors are used, and these are JAK-STAT pathway inhibitors we have to remember from this slide. Okay, so this is again table from Nelson. So we will not remember all the table. I'll just highlight the important things which you have to remember. So interferonopathies usually young age at onset. Several affected individuals are there. Many clinical features are there like encephalopathy, paresis, developmental delay we have seen, and in CSF like elevated pterin-neopterin ratio in CSF, elevated interferon alpha activity in protein in CSF. Okay, and calcification in CT, and chilipians like necrotic vasculitis of fingers, nose, ataxia we can see. Okay, then failure to thrive in which condition seen is ACP5 mutation, TME173 mutation, and lung features interstitial lung disease. Vascular features we have seen calcification of aorta and blood vessels. Ophthalmological features we have seen glaucoma, kidney features lupus nephritis, and dental abnormalities retained primary teeth and early loss of permanent teeth. Just remember these highlighted things which I have highlighted. So don't mug up the whole table. Okay. Then I have just created a summary of this like all the variants. So AGS has variant 1, 2, like 3, 4, 5, 6, 7. So just go through, and 1, 2, 3 are like classical AGS variant. Which variant is associated with dysmorphic features? AGS5. Which is associated with deforming arthropathy is AGS5. And bilateral strial necrosis is associated with AGS6, and AGS7 is asymptomatic. Okay, just you have to remember. I will highlight for AGS like we can see now. So with dysmorphic features, yes, dysmorphic features, yes. Then we will highlight like deforming arthropathy, bilateral strial necrosis, and often asymptomatic. And these are classical. Okay, so 1, 2, 3 are classical AGS type. AGS4 is with associated with dysmorphic features. AGS5 is like deforming arthropathy. AGS6 is bilateral strial necrosis, and AGS7 is asymptomatic. Again, RVCL, we can see RVCL. This is acute loss of vision, cognitive decline. SPNCD we have seen. This is immune dysregulation. Sting we have seen. This is due to pulmonary cutaneous involvement. And the gene you can remember from this table, like these genes are important. Just remember these genes. Okay, and TREX1 is 1. Okay, just remember these genes. These are important. Okay, so next part of this table is we have seen SAVI, proteasome associated autoinflammatory syndrome. Some more syndromes are there. So lipodystrophy, hypergammaglobulinemia. We have seen IHG15 deficiency. This is seizure, microbacterial susceptibility. We have seen SMS, dental dysplasia, aortic calcification. We have seen atypical SMS, which is DDX-AD, aortic calcification. We have seen THES, severe diarrhea, and trichorexis nodosa. So in this, from this table, just remember stroke, okay, spondylo and chondrodysplasia, lipodystrophy, brain calcification, dental dysplasia, aortic calcification. Okay, and just remember these genes. Okay. Okay, so yeah, so we have discussed all these things which are associated with interferonopathies. Okay, so yeah, we have done with all slides of interferonopathies. So I will just quickly revise. We'll just quickly revise in 5 minutes. Okay, so keep straight, and this is the crux of interferonopathies in next 5 minutes. Okay, so yeah. So what are the interferons? These interferons are protective mechanism of body. When we thought interferon could be associated with, because AGS, encephalopathy, SLE, and congenital viral infections had common spectrum, which led to investors to investigate the common mechanism behind them, which was interferon. So what is basically interferon? Interferon are protective molecules which are released by body cell when they are infected by virus or bacteria, and this is actually induced JAK-STAT pathway and interferon gene are produced and they kill bacteria or virus. When this mechanism is dysregulated, it caused interferonopathies type 1. These are mechanisms. Just remember, loss of function mutation of DNA RNA hybrid molecular degradation. Just remember, this is slide, you have just remember these mechanisms. This is table, this is photo from Nelson, so you don't go deep into this, just remember the previous mechanism. Again, the AGS syndrome, you have to remember the gene TRXE1 RNA SCH2B ADRI IF1H1. This is looks like pseudoTOD syndrome because developmental regression and intracranial calcification. And in CSF elevated type 1 interferonopathies and cerebral atrophy, JAK-STAT inhibitors we can use. Next, this is the slide you can we have discussed. Okay, SPENCD disease. So if patients come with skeletal dysplasia, with short stature, with plateys pointedly, with enchondroma, the diagnosis must be DD must be SPNCD. So the gene is ACP5, which encodes TRAP, enchondroma, intracranial calcification, SLE-like features, ACP5 mutation, autoantibody positivity. Next, SAVI, due to gain of function mutation of TMBM173 mutation, cutaneous vasculopathic rashes, violaceous plaques, nodule necrosis, and diagnosis by leucoclastic vasculitis, autoantibodies C-INCA, TMBM173 mutation, and this mimics granulomatosis with polyangiitis. This is the image, this can be asked. Then next, this is Candle, defective proteasome immunoproteasome dysfunction, PSMP8 mutation, POM, and this is interferon 1 pathway or lipodystrophy, all these. ISG15 deficiency, USP18 deficiency, IGS15 deficiency mimic AGS, and patient show vulnerability to viral infections. Despite impaired ISG15 don't show vulnerability. Okay, USP18, this is fatal in neonatal period. SMS, this is due to gain of function mutation of IF1H1. Clinical features like early onset aortic and valvular calcification, SLE or AGS phenotypes. Okay, so XLPDR, this is X-linked dominant, which is very important. POLA1 gene, early onset recurrent pneumonia, diarrhea, failure to thrive, enterocolitis, hypohidrosis, and skin hyperpigmentation. DNA second deficiency mimics monogenic SLE, and this is severe anemia, thrombocytopenia, hepatosplenomegaly, and ANA double stranded DNA antibodies, interferon stimulated gene expressions. So in SLE, basically monogenic SLE is associated with DNA second, DNA SE1L3 and DNA SE1 all linked to interferonopathies. Okay. JDM, yeah, this is also associated with JDM, and treatment is JAK-STAT pathway inhibitors. You can remember these drugs which are highlighted, and this is the tables. You can go through these tables once you have revised all these. So this is the lecture series 1. We'll discuss all topics regarding NEET SS in next 90 days. So this will lay strong foundation for your exam. You can revise from these lectures, and yeah, stay tuned for upcoming lecture on this amazing and fabulous series. Till then, bye.